Good morning. Thanks for the kind introduction, sir. So, going straight to the topic, BPPV is the most common cause of vertigo. So, though not fully understood, BPPV is thought to arise due to the displacement of otoconia from the macule of the inner ear into the fluid-footed semicircular canals. So, it is practical to think that once you reposition those things to where it belongs, so the symptoms should settle. So there has been studies which shows that compared to placebo, it is effective almost 81%, and placebo is almost 37%. Uh, so introducing the speakers. The pro speaker is Mr. A.K. Wirtz, who is a senior consultant neurologist in CHMRC Udaipur. He did his MBBS and MD from R&T Medical College, Udaipur, Rajasthan, and he did his DM Neurology in 2005 in PGMR, Chandigarh. He has almost 20 publications in national and international indexed peer-reviewed journals, first to identify and report apogeotropic variant of the posterior semicircular canal BPPV from India in 2020, largest series of horizontal canal BPPV published from India, and he has authored 3 chapters. The con speaker is Mr. Dr. T.K. Bannerjee, is the medical director and chief consultant neurologist, National Neurosciences Centre, Kolkata. Dr. Bannerjee has participated as plenary speaker and co-chair in numerous international conferences. He has 63 major publications and 29 publications, abstracts in leading peer-reviewed international journals. He is a member of editorial board and reviewer of several international journals. The moderator is Dr. Ramataraknath, is currently the chief neurologist, Amaravati Institute of Medical Sciences, Guntur. He is Emeritus Professor of Neurology, NTR University of Health Sciences, and former Professor of Neurology, Department of Neurology, Guntur Medical College and General Hospital between 1993 and 2004. He has delivered lectures in several national and international conferences, including 2 lectures in MG Hospital and Harvard School, Boston, USA. He is the recipient of Sri Tumala Rama Brahmam Memorial Research Award for the Best Scientific Paper for the year 2001 and Non-Pupillary Cerebral Venous Sinus Thrombosis and Best Teacher Award NRA Medical College in 2016. The chairperson is Dr. Rajiv Anand. He is presently working as Senior Director, Department of Neurology at BLK Max Super Specialty Hospital, New Delhi. He always looks out for accuracy in clinical diagnosis and treatments, focuses on treatable neurological disorders and cost-effective therapies in neurology. Dr. Rajiv Anand has a passion for making a difference in the care of a patient with neurological disorders. So let's move on to the topic. I think the poll has.
Yes, studio, if I can request you to please start the poll.
So the opinion poll is BPPV only maneuver enough. The audience has to select yes, no, or not sure.
So we'll give them 30 seconds. Just hold on. Dr. Prabhash, you can now declare the result. I hope you can see it on the screen.
Yes.
And then hand it to the pro speaker.
So the question was BPPV only maneuvers are enough. The answer, these 66.67 people are opined that it's no, and S is 22.22, and not sure is 11.11%. So it's more in favor that it's not that only maneuvers are enough. So let's move on to the talk. I'll invite the pro speaker, Dr. A.K. Wirtz, to start the proceedings.
Yes,
Sure. Dr. Watts, now you can upload your slide. Yeah, I think it's coming up.
Should I start?
Yes, sir. Please go ahead.
BPPV, benign paroxysmal positional vertigo. Only maneuvers / physical therapy are enough. My views are favorably disposed towards maneuvers alone. These are my declarations. So, the vestibular system and organs are semicircular canals that sense angular head acceleration and otolith organs that sense the linear head acceleration. True external vertigo indicates an abnormality of semicircular canals or their central connections that process signals from the semicircular canals. Floating or tilting sensation may indicate an otolith system disorder. So, vestibular labyrinths, which are paired structures in human beings, the CNS receives signals from both right and left membranous labyrinths and collates these signals. In stationary head, the tonic discharges from both vestibular efferents are exactly balanced. During motion, the right and left membranous labyrinth are alternately excited and inhibited, leading to a left-right difference in the vestibular nerve activity, which is recognized as motion. So, see, there are a pair of semicircular canal which work as a York pair. For example, when there is an angular head acceleration and right posterior semicircular canal depolarizes and increases its rate of firing, the left anterior semicircular canal hyperpolarizes and decreases its rate of firing to the same extent. And this is also holds vice versa, and this also holds for the two horizontal semicircular canals, so that when the right horizontal canal depolarizes and increases its firing rate, the left horizontal semicircular canal hyperpolarizes and decreases its rate of firing to the same extent. So this is a steady state maintained of no vertigo during the angular head acceleration due to symmetrical firing of the paired York canals, which is shown by animation in this diagram. So the anterior canal on one side is with the posterior canal on the upper side. So what happens during the peripheral vertigo, especially in BPPV? Why does the BPPV causes vertigo? Owing to the free-floating otoconal debris in canalolithiasis or a cupula that has been rendered heavy and gravity sensitive in cupulolithiasis, there is an inappropriate stimulation of canal even after cessation of head motion, resulting in a short duration of asymmetry in vestibular efferent input to the CNS that triggers positionally triggered vertigo. So this is the reason why the vertigo occurs in BPPV, either canalolithiasis or cupulolithiasis. And what do we do during the diagnostic positional test? The patient's head and body are oriented such that there is a ampulofugal or ampulopetal cupular deflection of the involved semicircular canal that generates the oculomotor patterns pursuant to the Ewald's law that localizes and lateralizes the involved semicircular canal. Julius Ewald, in his experiments in pigeons, framed the laws that bear his name. He cannulated each of the three semicircular canals and applied positive and negative pressures to observe the intensity and direction of the generated nystagmus. Two main outcomes of his experiments are that the generated nystagmus is always directed to the parallel to the plane of the stimulated canal, that is the Ewald's first law. That is what we actually do during the positional test. The generated nystagmus is stronger when the endolymph moves towards the ampulla, that is the ampulopetal cupular deflection in case of horizontal semicircular canals. This is the Ewald's second law. And away from the ampulla, that is ampulofugal cupular deflection in the case of vertical semicircular canals, that is the Ewald's third law. This is what we observe during the positional test and lateralize and localize the involved canal. So with that in background, what is done during the BPPV treatment? The non-ampullary arm of the semicircular canal has a utricular exit through which the otoconia inappropriately move out of the utricle into the semicircular canal. And this is the point where the non-ampullary arms of the posterior and anterior canal, they meet to form a cross commune, and it is the non-ampullary posterior arm of the horizontal semicircular canal which has the utricular exit. And this is the only way they can be repositioned back, because the cupular barrier at the ampullary arm, at the ampullary dilatation, is impervious to any movement in and out from the utricle. So during therapeutic repositioning maneuvers, sequentially orientation of the head and body of the patient is done so that the otoconia are displaced from semicircular canal towards the utricular exit under the influence of gravity. In cupulolithiasis, the inertial forces are generated by head shaking or mastoid exhalation to disengage the otoconia adherent to the cupula, or by making use of the gravitational force during the forced prolonged positioning, the otoconia are facilitated to drop down from the cupula. With this physiology mentioned, pathophysiology and physiology discussed in previous 7 slides, I am coming to some examples. This is a posterior semicircular canal BPPV. This lady had vertigo for around 2 days. The Dix-Hallpike position test in the right head hanging position elicited an upbeating nystagmus with a torsional component. The upper poles of the eyes are beating towards the patient's right ear, and that is lateralizing the canal to the right side. This is important to know why this oculomotor pattern has generated. The excitatory projections of the right posterior semicircular canal are to the right superior oblique and left inferior rectus. That generates a slow phase because of excitatory impulses in the right posterior ampullary nerve, and that leads to primary contraction of the right superior and left inferior oblique. And this slow phase VOR is downbeating and left torsional. The fast phase VOR, which is a refixation saccade and is clinically appreciable as positional nystagmus, is therefore upbeating and right torsional, as we saw in this case. And this is how the Dix-Hallpike position moves the otoconal debris near the ampullary end of the right posterior semicircular canal away from the ampulla, that is the ampuloflugal cupular deflection occurs. So what is done to treat such patient? One of the maneuvers is Apley maneuver. The patient is taken to the position that elicited the nystagmus, that is the Dix-Hallpike position, maintained in this position for around 1 minute, and after which the head is inclined 90 degrees to the non-involved side, and this position is also maintained for around 1 minute, after which the patient is taken to the non-involved lateral recumbent position with the nose pointing downwards, and this position is maintained for another 1 minute, after which the patient is uprighted to the short sitting, completing the 1 Apley maneuver. And this is how the otoconal debris moves from near the ampullary end of the right posterior semicircular canal towards the cross commune, into the cross commune, and finally into the utricular matrix, and thus clearing the canal. Now this debris is no longer available to cause the asymmetrical stimulation of the membranous labens when the head moves relative to the gravity. A verifying right supine, a right Dix-Hallpike test done in this patient after 1 hour did not elicit any nystagmus, and the patient was free of vertigo as well. This is one of the cases which is the most common garden variety of the most common frequent variant of the BPPV. The second case is a 19-year-old male patient who had vertigo for 2 days. Here the supine roll test elicits a geotropic right-sided geotropic nystagmus on right lateral head roll with the quick component beating towards the right ear, the lowermost ear. And it is important to note that the supine roll test has to elicit the nystagmus identical pattern on lateral head roll to this side, and the lateral head roll to the left elicits a even stronger geotropic nystagmus. And in the geotropic variant of the horizontal canal BPPV, the side that elicits a stronger nystagmus is the involved side, and this was treated as a left long non-ampullary arm horizontal semicircular canalolysis with the Buffoni maneuver. From short sitting, the patient was taken to the contralateral non-involved lateral recumbent position, maintained in this position for around 1 minute. Then the head was inclined downwards, the yaw axis, and this position was maintained for 2 minutes, after which he was uprighted. A verifying supine rule test was done after 1 hour that did not elicit any nystagmus on lateral head roll to left or to the right, and thus the patient did not have vertigo as well, and this testifies the robust response of the positional maneuver, that is the therapeutic positional maneuver, Buffoni maneuver, done to treat this patient. The third patient is, this is how the otoconal debris moves from the long posterior arm of the left horizontal semicircular canal to near the utricular exit into the utricle and finally clearing the canal. This is a lady, 32-year-old, had vertigo for around 7 days, positional on either of the lateral recumbent positions. The lateral head roll to the right elicited an apogeotropic nystagmus. This was quite a long nystagmus of 3 minutes duration. So I am scrolling it to 3 minutes. It is still present. And to the lateral head roll to the left, again it elicited a nystagmus which was weaker as compared to that elicited on the right side. It was of 1 minute duration. And so this patient had left-sided horizontal semicircular pupulolithiasis. She was treated with head shaking maneuver. With the patient in short sitting, the head was anti-flex around 30 degrees and shaken side to side in 30-degree excursions for 30 seconds. And a verifying supine roll test was done after 1 hour that did not elicit any nystagmus on lateral head roll to right. You can see absolutely static eyes here as well as to the left. And the patient of free of vertigo. The response, the robust response to the horizontal semicircular pupulolithiasis implies that in this patient, the otoconal debris, which was adherent to the utricular site of the cupula, by the inertial forces generated as a consequence of the head shaking, was disengaged, and as it directly dispersed into the utricular matrix, the patient had a complete relief of vertigo. Reasons for inadequate response in maneuvers are incorrectly chosen maneuver, 3 eyes, inappropriately executed maneuver, inadequate number of maneuvers. The number of positioning maneuvers is not clearly specified. In one of the papers from the Bhattacharya, Neil Bhattacharya et al. In 2017, a total of 5 were effective in almost 100% of the patients with posterior canal. A total of 2 Goffoni or Appiani maneuver are effective according to the position paper or the RCT paper from Mandala and Kim in 2012 and 13. Anterior semicircular canal BPPV not clearly specified in most studies. My personal choice is 5. So these are the next 3 slides are the literature I am citing from the giants Michael Stroop and Thomas Brandt. Because of the pathomechanism of BPPV, anti-vertiginous substances are not sufficiently effective against symptoms in long term. The only exception is sensitive patients who develop severe nausea after a single maneuver. In this case, dimenhydrinate 100 mg half an hour before performing the liberatory maneuver can make the therapy easier. Likewise, according to the Robert Ballo, the drugs like meclizine or promethazine have relatively little use in the management of BPPV because acute attacks are not suppressed by these drugs and PRP are much more effective. These are the clinical practice guidelines of the American Academy of Otolaryngology, Head, Neck and Surgery, published in 2017. They recommend against routine medications based on observational studies and preponderance of benefits over harm. The exceptions have been noted: severely symptomatic patients refusing other form of treatment and patients requiring prophylaxis for CRP. So my final take is repositioning maneuvers and or physical therapy is the only recommended form of treatment in majority of BPPV patients. Identification of semicircular canal, that is localization and site lateralization, is pertinent if the diagnosis of BPPV is to be considered. Vestibular suppressants are neither useful nor recommended. The 3B recommendations, as I call them, from Brandt, Ballo and Bhattacharya. Singular neurectomy and posterior semicircular canal occlusion may be considered in resistant cases. That is my final take. Thank you. I finish my lecture here.
Now I request Dr. T.K. Bannerjee, the CON speaker, to present his talk.
Is it visible? Right.
Yes,
my
sir.
slide visible?
We can see it. We can see it, sir. Go on.
All right. Good morning, friends. Actually, my predecessor has spoken extremely well to present his case, and he has spoken in support of the motion. My task is to speak against the motion. So, I mean, as he has very well said, the underlying mechanism of BPPV is that there is migration of otoliths from this original place in the utricle into the semicircular canal or into the cupula, and that leads to some kind of abnormal sensory afference going to the brain, and which is manifested clinically as vertigo. So the rationale for treatment in this case is to reposition these otoliths from their migratory semicircular canal condition to their original position in the utricle. And my predecessor has very well demonstrated the maneuvers that has been so effective to reposition them and treat this disease. But is that enough? So I have a few points to say that this particular repositioning maneuver is not enough. Point number one, you see, he has mentioned that in posterior canal BPPV, which is the commonest type of BPPV, and the particular maneuver, which is the way of treating it, the Epilepsy maneuver, is effective in 70 to 85% of cases. In horizontal canal BPPV, the Buffoni maneuver has a response rate of 61%. Barbecue roll has a response rate of 70%. In superior canal BPPV, which is of course extremely rare, again we go for the Epilepsy maneuver, which has a response rate of 76%, and Iacovino maneuver has a response rate of 79%. So what does it indicate? It indicates that around at the most 80% of the cases, this repositioning maneuver is effective. So there is around 20 to 30% of the cases which in case conditions this repositioning maneuver is not effective. So that means that repositioning maneuver RPM is not enough. Now, in those cases, there are resistant cases, and in those cases, we go for this sophisticated patient positioning system, like we use the mechanized devices like apnea-onmias rotator, the TRV chairs, and other forms of vestibular rehabilitation therapy to get the benefit. Or we can go for posterior semicircular canal occlusion, where we plug into the particular semicircular canal, thereby collapsing the semicircular canal and eliminating the abnormal sensations that pass out from there, and thereby abolishing the BPPV. In extremely refractory cases, we may even resort to surgical intervention like singular neurectomy, which is performed. The benefit of posterior semicircular canal occlusion over neurectomy is that it can preserve hearing. But in very resistant cases, we may have to resort to singular neurectomy. The point number two that I have, where RPM is not enough, is that in nearly 5% of the cases, when you do this repositioning maneuver, the otoliths may be displaced from the posterior canal into the horizontal canal. So patients, rather than getting relief from their vertigo, can lead to another positional vertigo by migration of these canaliths not to this original position in the utricle, but to another semicircular canal. And that has been observed in almost 5% of the cases. So by doing RPM, we are not really giving benefit to the patients. Point number three, why I say that RPM is not enough, is the fact that in a substantial number of patients who have undergone RPM, they develop a phenomenon which we call post-RPM disequilibrium syndrome. And what exactly happens in that case is that it's characterized by this dizziness, these spells of dizziness that occur during change of head movement, during walking, during change of position in bed. And it is not really true vertigo, but a kind of dizziness or unsteadiness that the patient feels. And that happens in around between 30 to 45% of the cases. So that is not an uncommon phenomenon that happens, and that lingers on for 2 to 3 weeks and even beyond a month. The underlying cause is said to be some kind of sympathetic autonomic dysfunction. This sort of phenomenon is a very real entity, and after the repositioning maneuver, this sort of symptom happens. So RPM has not been enough to really give a full relief of the patient in BPPV. And there are, of course, the other kinds of options that we have by which you can shorten the duration of post-RPM disequilibrium syndrome. One is this vestibular rehabilitation therapy, or we can use beta histidine at the dose of 12 milligram 3 times a day for 4 weeks after this RPM has been performed. Now, this is one study which was published in a Chinese journal only this year, where they recruited 129 cases of BPPV patients who developed this post-BPPV residual dizziness, and they were assigned randomly to 3 groups, 43 patients in each arm. One group, they are the control groups. They did not receive any specific treatment after this procedure, maneuver. But the other 2 groups, one received rehabilitation, intense rehabilitation training for 4 weeks. Another group received beta histidine at a dose of 12 milligram of beta histidine 3 times a day for a period of 4 weeks. And it has been observed that the median number of days where you do not give any treatment after this, they develop this post-BPPV, post-RPM disequilibrium syndrome. It lasts for 19 days. But when we assign them to this group of vestibular rehabilitation therapy or to beta histidine, you can shorten the duration to a median of around 14 days. So these type of other options actually shortens the duration of post maneuver disequilibrium syndrome or dizziness. There was another study which was published, and that was actually published in the American Academy of Neurology. Here, patients received beta histidine at a dose of 48 milligram daily for 7 days after the Epilepsy maneuver when they developed this disequilibrium syndrome, and they found a much better outcome in relieving these patients from this disequilibrium when we applied them beta histidine 48 milligram per day. Now, there are certain cases where this post-RPM disequilibrium may persist for a longer period of time, more than 1 month, and are said to be more prevalent. Those where this maneuver is done when they are above the age of 65 years, when the patient has associated anxiety or depression, when the duration of this BPPV before the maneuver was administered was a much longer duration, and when multiple sort of maneuvers were needed in a particular patient. This was a study which was published in Clinical Neurophysiology 2014. And there, 90 patients with idiopathic BPPV were treated with repositioning maneuver. Of them, 38% reported residual disequilibrium on the second day after the successful repositioning maneuver. And the mean duration of this disequilibrium syndrome lasted for between 11.6 plus minus 3.9 days. Now, those cases where the duration of BPPV was for a longer duration, with a median duration of 14.1, had a higher chance of developing residual disequilibrium. But those cases where the duration of BPPV before the maneuver was administered was shorter, with a median days of 10.9 days, there the residual disequilibrium was less, and there was statistically significant. So there was a correlation demonstrated between the duration of BPPV before the maneuver was administered and the duration of the residual disequilibrium. That study also demonstrated that anxiety plays a role in increasing body sways. Now, in this retrospective study in 361 patients with BPPV of any semicircular canal, the study showed a disequilibrium in around 30% of patients. Now, no matter which canal is involved, which semicircular canal is involved, there was no significant difference between the rate of developing this disequilibrium syndrome. Now, those patients who received more than one repositioning maneuver, in this study, 229 patients received one maneuver and 132 patients received two or more maneuvers. And it showed there is a significantly higher prevalence of instability or disequilibrium in those who received two or more maneuvers. So you can see here 17.9% when they had one maneuver, and 50%, as many as 50%, if two or maneuvers are needed in these patients. It is statistically highly significant. And 47.2% of patients with anxiety who had an underlying premorbid anxiety, they presented with more of this post-maneuver instability syndrome in BPPV. And patients who are older than 65 showed also a significantly higher percentage of residual disequilibriums. Now, another point number 4, why I say that this repositioning maneuver is not enough, is that 12% of all BPPV are actually multi-canal BPPV. And there are two types of multi-canal BPPV. In the first category, there is unilateral involvement of posterior and horizontal canal on one side. And the other type of BPPV, where on both sides, both posterior semicircular canals are involved in this BPPV. And these multi-canal BPPV are quite often resistant to single repositioning maneuver. They may require multiple sittings. Sometimes they say the one which is more affected, you do the maneuver there first and then go to the other semicircular canal, which is less affected. And this post-BPPV disequilibrium syndrome is more common in multi-canal BPPV. So many of these patients do need, this maneuver is not enough really, and they need this sophisticated vestibular rehabilitation therapy. You need those mechanized devices like Epilepsy rotator, TRV mechanical chair. So in many of the cases, these things are needed. So actually, I rest my case here saying that RPM, repositioning maneuver in BPPV, is not enough. There are other options you have to resort to in really giving benefit to these patients. Thank you very much.
Now I would request Dr. Ramatarak Nath to present his views as the moderator.
I congratulate both the speakers, both the pro and the con speakers, for their excellent talks. And I agree with Dr. Watts in the sense that patients who persist to have complaints, you should always look for inappropriate repositioning, inadequately done. So the thing that you should ask in the history is, if the patient, ask the patient if he continues to be symptomatic, whether it is that original rotatory vertigo or the disequilibrium syndrome explained by Dr. Bannerjee. Because many patients, if you ask, as long as the particles are still in the canal, they still persist to have the rotatory vertigo. But once they have been repositioned, where are they going? They are going into the utricle. So in the utricle matrix, something fresh has been added now. So what happens is they continue to have the disequilibrium. Mind you, it is not the rotatory vertigo. So for the disequilibrium, which Dr. Bannerjee has mentioned, this is probably one assumption that I think, because if you always go back into the history, if the patient is patient continues to complain of that vertigo after repositioning, ask him, what is the kind of dizziness that you have? Is it the original rotatory vertigo that you have, or is it the disequilibrium? If it is the disequilibrium, probably all the particles have freshly been added into the utricle of the utricle. So therefore, they continue to be unsteady, and therefore there is a case for giving anti-vertiginous drugs. So most important thing is, if the patient complains of vertigo, you need to go back and ask in the history and see whether it has been an inadequately done procedure, or because many times if you do immediately, even see what is the definition of vertigo? Benign paroxysmal positional vertigo. It fatigues, it disappears. There's no point in saying you have done it again and it has not come, so it is cured, because it is known the particles will disperse. So therefore, you may not get it if you do it immediately. Again, you do it after an overnight's rest, you may still get it. That indicates that the particles are still there, free floating. The only thing, they are dispersed. Now, after the overnight sleep, if you do it, you will find that there is still some particles left. Then you will get the rotatory vertigo. But after that, if they continue to complain of disequilibrium, mind you, they will feel just unsteady, being pushed to one side. And those patients are the ones which have post-repositioning disequilibrium syndrome, where you need to give the antivertiginous drugs. That's my take on this. I hope it's clear.
So, Dr. Taraknath, there are no further questions from the audience. So you can go ahead and invite the speakers for their own rebuttal points to support their stand.
Sure. What do you think, Dr. Watts?
Sir, I do agree with the differences you made. I would add just one thing. If the patient continues to have vertigo, residual vertigo, the thing is that when should you do the verifying positional tests? After 1 hour, 24 hours? I think both at 1 hour and 24 hours are important, because we need to know whether there is elimination of the positional nystagmus, which we initially saw, and plus if any possibility of canal switch, which Dr. Bannerjee mentioned, and if the canal switch has occurred, which is very common, especially from posterior to the horizontal semicircular canal, you need to give a different maneuver at that time, and then again do a verifying positional test.
Yeah, it is done. But what I'm trying to say is, once the particles are dispersed, you may not get that same intensity or nystagmus if you do it immediately. So therefore, you should not assume, okay, this patient has been cured. Still, they continue to complain. It is dispersed.
Yeah. In majority of the papers where they have done randomized trials, they do the verifying the positional test after 1 hour as well as after 24 hours. Secondly, adding to that post BPPV syndromes, as the particles are repositioned into the utricle, it's very common for those who have been involved personally in that, as the patient is taken upright from the aplay position. Sometimes you see that there is severe disequilibrium. The patient tends to fall either forward or backward. It is something like the Tomarkin syndrome, which occurs in Meniere's, and that is because of the repositioning. There is sudden utricular excitation at that moment. So the thing is that as they are repositioned back into the utricle, it adds a mass to the utricular matrix, and that is the reason for the disequilibrium, and that is a different entity. I do agree with that. I never said that the only maneuvers are effective, but I included that in majority of the cases. My rebuttal about
continues for a few weeks. That's why you need to continue the drugs in those patients where the disequilibrium continues even after the repositioning. Because the particles, if once they are not in the canal, that rotatory element is gone. They just have the disequilibrium.
Secondly, the multiple canal BPPV will have will require more than one maneuvers, because we need to reposition the otoconal debris from two different canals whose orientation in the space is different. So we need to do it in several settings, because sometimes if the horizontal canal BPPV is involved, that is very common with the unilateral posterior and horizontal semicircular canal BPPV. It will have severe symptoms of nausea, vomiting, and perspiration, because we know that horizontal canal BPPV has a severe vegetative symptoms. So I think that has to be done because of the inherent nature of the disease. Multiple maneuvers are required, and that is why the post BPPV syndrome is more common in that patient. That is my rebuttal and my take.
I'm sure everyone must have experienced that patients have typical history of BPPV. When they lie down, they get it. But they would see some doctor or go over the counter drug, take a Stemetil and come. When they come to the clinic, when you'll not get it. You will not get the positional test positive. So that means it is when the vestibular suppressants, they are going to help in vertigo, at least to a certain extent in these patients. I'm sure you would have had the same experience.
Dr. Taraknath, if you could request Dr. Banerjee to give his rebuttals, and then we move on to the polling and the final words from Dr. Rajiv Anand.
Go ahead, Dr. Bannerjee.
Right. I think my colleague has given a wonderful sort of message that this is a procedure which has to be done one has to identify what is BPPV, and the message should go across to the doctors that just giving vestibular sedative is really counterproductive. It should not be done. Identify these sort of patients, and they should go for this repositioning maneuver. That is true. You should not give them those dimenhydrinate or other vestibular sedative that will prolong, that might have a symptomatic relief, but will prolong the problem. So the treatment is simple, you go for the maneuvers. But then again, one thing that I have, that what is said that to do a disc Hallpike maneuver 1 hour after doing a successful repositioning, sometimes carries a small risk of again displacing the otoliths from the utricle right into a semicircular canal. I mean, that has been demonstrated in a few cases that leads to, again, this, displacement of the otoliths, the semicircular canal. I would like to have the opinion of my colleagues about it.
You are right, sir, because there are studies, if it is done earlier than whatever, if you are doing multiple maneuvers in any session of treatment, if you have done one maneuver, wait for at least 15 minutes to repeat the maneuver or to do a verifying positional test, because the openings of the common crus and that of the non-utricular exit of the horizontal semicircular canal are very near. So there is a chance that if you do a positional test again, or you do a apply maneuver or any other maneuver again, the otoconal debris which has been repositioned back into the utricle may go into the horizontal semicircular canal. So that is the reason for the canal switch. And if the patient remains upright during that time, say for example 15 to 20 minutes after doing the maneuver, the otoconal debris which has been repositioned back into the utricle is theoretically expected to disperse into the gelatinous utricular matrix, and so it will no longer be available near the openings of the common crus and the non-utricular, non-ampullary exit of the horizontal semicircular canal to cause a canal switch. That is my take.
Sure. Dr. Taraknath, if I would request you to please now hand it over to Dr. Rajiv Anand for his final concluding remarks and the post-debate polling also.
Over to Rajiv.
Yeah, so a lot of knowledge has been added to by two eminent debaters. In fact, they agreed on most of the point with each other also. So probably the debate was a source of knowledge that which are the cases which are going to respond to repositioning maneuver and what are the problem when repositioning maneuver do not work. So can we have the poll first? Post debate poll, is it available?
Yeah, sure, Dr. Rajiv. I think you can see it on your screen now.
Yeah.
We'll allow them 30 seconds to answer the question, and then you can give your concluding remarks. Yeah, Dr. Rajiv, I think the results are out. Yeah.
Okay. So there has been actually the debate, according to the audience, goes in favor of Dr. Bannerjee, who has won by, and in fact the poll has also swung in his favor, that repositioning maneuvers are not the only. Actually, it is the nomenclature of the debate is difficult to defend. Even Dr. Wirtz is not saying that repositioning maneuvers are not the only treatment. And both of them agree on repositioning maneuver as being essential. So What we know about BPPV is what we have learned from two speakers who have spoken so eloquently, that it is a entity which needs to be correctly identified in terms of which canal is involved. Also, you have to institute the correct maneuver so that to have a majority of the patient responding to the treatment. That's the mainstay of treatment in this. But it has also been stressed that almost around 30% of the patient will continue to have some symptoms post repositioning maneuver, which, as Dr. Tarak said, you ask the history again, whether patient has persistent vertigo or patient has persistent dizziness. And I also add that in one of the slide, Dr. Bannerjee added that anxiety is a prevalent symptom. So we must address to post-repositioning maneuver symptoms by accurate diagnosis and the drugs which help the patient better. So this is what we have learned from both the speakers. Both the speakers have concluded, and I add to that we must address to accurate diagnosis, accurate repositioning maneuver, and addressing post repositioning symptoms also. Thank you.